Welcome everyone to the Understanding School-Based Mental Health and Medicaid webinar series. This 5-part series is designed to build a shared foundation of understanding how Medicaid supports mental health services in both school-based and community-based settings across the state of Illinois. The vision of this series is to support the provision of mental health services to students within school settings to reach all youth, and especially those that may be most vulnerable that cannot access services otherwise. My name is Matt Buckman. I'm a licensed clinical psychologist, duly credentialed as a school psychologist, and also the executive director of the Stress and Trauma Treatment Center. I will be guiding you through today's content and this 5-part series. This webinar was developed with support from the U.S. Department of Education's School-Based Mental Health Services Grant awarded to West 40 Intermediate Service Center No. 2 in partnership with the Stress and Trauma Treatment Center. This material is provided for educational purposes as a broad overview. It does not replace the official guidance from HHS, CMS, or the Illinois Department of Healthcare and Family Services. Regulations and compliance requirements can change, and participants should always consult authoritative sources. This is a 5-part series. This series progresses from foundational Medicaid concepts to increasingly more specific applications. Starting with a foundational understanding of Medicaid allows us to dive deeper into the school-based reimbursement system, community mental health services system and reimbursement for this, and specialized care coordination service organization and pathways programs. The final part of this series will be a discussion of ideas for action, which will build on the previous content and identify concrete steps or strategies to leverage funding to increase access to mental health services for students. Part 2. In this segment, we're going to take a deep dive into school-based mental health and Medicaid reimbursement in Illinois. Some of the areas that we're going to discuss during this part are the essential steps and a roadmap to Medicaid reimbursement using the Healthy Schools Campaign MESH project. Medicaid reimbursable activity codes, we're going to go into depth of each of these and some that are unallowable reimbursements and others, how they're being reimbursed throughout the state of Illinois. We're going to break down for Medicaid administrative claiming, direct service claims, and how the cost settlement model works within each one of those. And then lastly, like with every part, we're going to leave you with some useful resources if you want to dig in more or continue to further learn in any of these areas. Medicaid reimbursement for schools. We know there's lots of different service providers that are already eligible for reimbursement for Medicaid enrolled students. At this particular point, we're looking at our FMAP, our federal medical allowable percentage. And within that, in our Medicaid administrative activities, that FMAP is 50% or the minimum amount. For direct service activities, as we'll talk about and you'll be able to see models for, that is using the state FMAP or specific percentage to the state of Illinois. The big change in our expansion or state plan amendment is that services no longer need to be tied to an IEP or an individualized family service plan under the free care rule. And I'll talk about from a reimbursement standpoint, one of the most significant changes is moving from a rate model or rate settlement model to a cost settlement model, and that cost settlement model is actually one of the biggest contributors in increased reimbursement across the state of Illinois. First, let's look at some successes. And even though the plan went in and several years later it was approved by CMS or the federal government, we still saw increases, even without a lot of knowledge about what to do or how to do it, or the information that's presented here within this webinar series. Even without that information, we still saw increases in year one of $18 million across the state of Illinois, and year two, $23 million across the state of Illinois. And hopeful that year 3 and year 4 and year 5 continues to see increases, and that you as a participant of this webinar series, that you're going to learn some techniques, strategies, or information that allows you to be able to capitalize on or increase the utilization of Medicaid reimbursement within your district. Something to note about where does this money come from? So there's 315 million in FY23, and the reason why we only have data for FY23 right now is that FY22 was paid out in 2024 and FY23 was paid out in fiscal year 2025. And FY24 will be paid out in fiscal year 2026. And so we're always looking at about a year and a half to 2 year payout process, which is what's utilized for the cost settlement model. And so that is a delay. And we were seeing delays even before this model. So that is something that you could naturally expect. And so we'll talk about some ways to be able to deal with cash flow, such as interim billing and some of the administrative services or administrative claims. But the total reimbursement for FY23 was 315 million. Of that, administrative services or Medicaid administrative claiming, MAC, that represented 82.6 million. Interim direct service billing, which would be the services to students with IEPs or students without IEPs, that interim billing was $110 million. And then the cost settlement was $121 million or $122 million. And the cost settlement, I'll talk about how that relates to administrative claims and interim billing throughout this presentation. Something to note as we're looking at school-based mental health providers and services. And although Medicaid billing and reimbursement is definitely bigger than that, I want to point out that psychological, social work, counseling services make up the largest majority of the total direct service reimbursement that is contributed over to administrative claim billing and interim billing. So school-based mental health has a healthy chunk and a lot of potential for what can be reimbursable through Medicaid in your district. So what do school-based health services programs cover? As we talked about, now we can have any type of plan of care or medical necessity documented that doesn't require an educational diagnosis or special education diagnosis or an individualized education plan or individualized family service plan. That is a significant change that we're looking at. And within that, all services that are medical services for an individual with Medicaid with medical necessity and a plan of care documented, that those services are covered. Also, all administrative services for the population of Medicaid, those services are also going to be covered. And there's different kind of proportional Medicaid rates that may apply to one versus the other. And I'll talk about outreach as a specific important outreach and determination for Medicaid eligibility as specific important administrative services that can produce the highest amount of reimbursement to the district. I'm going to use this provider example, and with this provider example, this school-based mental health provider, their salary is $75,000 a year. The fringe is $23,750, which includes insurance and other types of costs, taxes, payroll taxes, things like that are included. And then the indirect rate for the district at 15%. But again, whatever your negotiated indirect rate is, that does apply to the cost settlement model, as well as to the Medicaid administrative claiming. That as long as you're doing your cost reporting, that will all factor into the amount that you're going to get reimbursement through Medicaid. So those quarterly reports, those cost reports are very essential, necessary, so that one, the appropriate amount gets reimbursed, and two, that you get reimbursements at all. So this person, we can see the total cost for this one provider is $110,000. We know that the overall cost for the district, you can put in rent, you can put in several different other expenses in your cost report. So then when you get to your Medicaid administrative claiming or your cost settlement, that this number is not just for this particular provider, but it may be much larger for some of that, some of those claims. As we are going through the map, this is the map I want to really reinforce for us. And this comes from the Healthy Schools campaign and the within that campaign, the Medicaid expansion for school health. This has been a wonderful resource to me, and I just want to give a shout out to that program and to this tool that you can find online for free. And in each one of these steps or processes, you actually can click on them and get additional guidance and information that can help you reinforce, build out, expand on whatever area you feel like you need to grow in within your district. As we go through this roadmap, one of the first very important steps in maximizing the amount that you can get for Medicaid reimbursement and through just being eligible for Medicaid reimbursement is identifying which service providers are eligible and which cost pool you're going to put each of those providers in. First, it's important that you are identifying the right providers for every cost pool. So cost pool one, that's direct service personnel. These are Medicaid eligible licensed individuals that meet the guidelines that you can find under the Medicaid system and under the U200 Handbook from HFS. All of these providers must provide some type of direct service to students that have Medicaid. And so that's how you're going to determine who's in this pool versus another pool. Other personnel that may be related to this can be administrators, can be paraprofessionals, can be transportation providers, can be administrative assistants or some type of case managers or other types of supports. Sometimes you might have a provider. Rarely will this happen, but sometimes you might have a school counselor or an educational social worker that does not ever provide services to students, never provides one-on-one services, group services, doesn't interact necessarily, and only does administrative work with students. Or administrative work, not necessarily direct service with students. In that situation, they would go in cost pool two. One of the strategies I'll talk about is it's important that we have all of our providers in cost pool one, and that will help us maximize reimbursement and make sure those who are providing services are getting the appropriate reimbursement that the district could be eligible for. As I talked about before, the free care rule, this can apply to 504 plans, but it doesn't have to be one of the traditional plans we're used to using within the school system. You can develop your own individualized plan of care, or plans can build off of another entity, maybe a medical provider that has given a diagnosis or made some type of recommendation to the school district, or another community-based provider that might have done that. So there's different ways of doing so. Within that, the plan of care and medical necessity does not necessarily mean you have to have a full criteria diagnosis. There are multiple ways to do that, but you do need to have a system to be able to determine who is eligible for these services, and that the services we're providing must relate back to that eligibility criteria of and medical necessity that will be there. And that's across the board for all Medicaid services. Some of the newly eligible providers that came in through the state plan amendment are ISB certified counselors. So these are school counselors that are certified through ISB, through the professional educator license, licensed clinical professional counselors, licensed marriage and family therapists, orientation and mobility specialists, licensed clinical psychologists, registered behavior technicians. As we're looking at this, the list has expanded significantly of who can provide services and how you can get Medicaid reimbursement for those providers within your district. First, I'll talk about PCG, and that's Public Consulting Group. That is the group that works directly with HFS. And when you get your random moment time studies, that's coming from PCG. But within this, you can look at this just demonstrates that there are multiple cost pools. And here are some of the new providers with existing providers that were already here. These providers are who is eligible for direct service personnel versus administrative service personnel or other direct service personnel. And school health aides in this, those are paraprofessionals. I want to point out the difference between educational social workers and medical social workers, that anybody who's providing direct services or providing, and there's definitions out there in the U200 handbook, but medical, as long as they meet that definition, if they're providing direct services related to mental health needs of a student, then they are a medical social worker, can be classified as a medical social worker. And school counselor versus ISB licensed counselor. Again, if they're providing services and supports, then they are ISB licensed counselor versus a school counselor in this determination here. I'm not necessarily saying this is what each one of those fields or disciplines, how they would define this. This is merely reflecting what the handbook for HFS in the state of Illinois and how this is classified, that these are questions or determinations that have to be made based on the Medicaid system, not necessarily the ideal system for defining provider types. In addition to identifying our cost pool, we need to do that, one, at the initial portion of the year, but also we need to update that throughout each quarter within PCG. So that is going to be an administrative task that is necessary to be able to ensure that you have the right provider types. Because if they're not in that, they can't get interim billing or reimbursement for fee for service, and their salary, benefits, et cetera, would not fit into the cost pool system or the cost settlement model later on, that the larger the eligible expenses are or costs are in your cost reporting, the more reimbursement you'll actually get. So you won't be able to put them in that if you don't have them in the staff pools, and if you're not including them in the cost reporting. One of the most basic steps, but many districts many of us are still getting to this point, is to make sure that we have parental consent to bill and share information with Medicaid. We get this already for special education students, but we have not been doing this necessarily for general education students. This consent for services, and ISB has a sample that you can utilize, or you can create your own version of that. But this consent is a lifetime consent. So it is not a yearly consent that you will see like with other community-based services or for your medical services when you go to the primary care doctor. This is a lifetime consent. So if I get this at pre-K or at kindergarten enrollment, this consent stays active until a caregiver or someone comes to us to be able to revoke that consent in some way. And they can do that. People can revoke, families can revoke it. But the point is, this is not a really administratively heavy lift outside of the initial point of getting that consent. And oftentimes we're doing that at school enrollment. And so there's already a lot of paperwork that we're doing. And so we're adding that in. But of course, it's up to your district and how you administer that consent and receive that consent. Throughout the process, we do want to have records so that if we are ever audited or if there's a site review of some sort that needs to prove that we do have consent on file, that we do have a treatment plan or service plan or plan of care of some sort, and that there is some type of medical necessity that's documented in that, and that the services that we provided and were reimbursed for were also listed in that service plan or plan of care. There can be a little, there's some of that compliance that's there that when we look at Medicaid reimbursement systems, oftentimes we're going to also see this in some of our ethical codes and some of the legal requirements for services that are being provided. And so they're going to match somewhat that we do want to have records of services that are being provided. And Medicaid will specifically give us some guidelines on what type of documentation is necessary. I've already talked a little bit about documenting medical necessity. That is essential, that you cannot get reimbursement from Medicaid without the services being considered medically necessary by your provider type. And so many times I'll have providers for school-based mental health, they'll be like, well, I'm not qualified. I'm not capable of doing so. And so that's maybe a confidence, a coaching, a training opportunity. But any of your providers that are qualified under Medicaid, when I looked at that cost pool list for direct service provider, they are qualified as long as that's within their specialty area. So like me as a licensed psychologist or school psychologist, I shouldn't be providing a physical therapy diagnosis. But if it's within my realm, that gives me that qualification to be able to determine medical necessity. And many individuals that you already employ have this ability to be able to determine that medical necessity. Here's a quick list of what the Center for Medicaid and Medicare Services will require as far as documentation of services that are there. These are very similar to what IDEA has always required for us. Difference is now we're going into free care and we're going to gen ed students at this particular point. And we need to be able to track the Medicaid identification number in the state of Illinois. That's the RIN, registered identification number, and that RIN that a student has, that number will stay with that student their entire life. So that's not a number that will change from year to year, or from when a student may move, or a family or a student may move from one managed care organization to another one. Maybe they had Meridian before and then they move over to youth care or whatever that might be. That RIN number stays the same even if the managed care entity changes. MESH and Healthy Schools Campaign has several types of internal program review checklist and ways to be able to, self audit and just make sure we have our own compliance down for the quality of our documentation, and that services are happening for the right students, that we have, kind of our checklist completed. Responding to the random moment time study is an essential part of Medicaid reimbursement in schools. This random moment time study feeds into many different systems, including the Medicaid administrative claiming, as well as the cost settlement model that is utilized, and that is the biggest chunk of money that ends up coming back into the district. Fee for service is also an important part of it, but the random moment time study is an essential element. Throughout the year, there are multiple time periods of when those random moment time studies do occur. It's important you have a short amount of time, 2 days, to be able to respond. It's very important that all staff respond to this. Now, for some districts, if they get less than 85% of a response rate, it could jeopardize the Medicaid reimbursement or funding eligibility for that particular school district. So we want to make sure that anyone that we're putting into the staff pools, that they are aware that the RMTS may be coming, and that is essential that we are completing that random moment time study when we get that information, and doing that accurately in a timely manner. There are some time study codes, and I'm going to go deep into this, but there's some overarching guidelines, as well as some specific codes that are most commonly used within school districts. So some of this information you may find is too deep, and some hopefully can still be helpful to you. So there's some descriptors when we're looking at our time study codes, and this also translates into our fee-for-service codes as well. These are the same Medicaid reimbursable service codes. This is what Medicaid says is unallowable, which is a U that you're going to see on each one of these slides, or you can see this in the handbook, um, or reallocated. That is not really counting. It's not counting against you, but it's not counting for you either. So it's reallocating that time to the other time study moments. Total Medicaid, that the only thing that's going to be in total Medicaid for school Medicaid health services is outreach or determination or redetermination activities to be able to help students identify whether or not they're eligible for Medicaid, and or families identifying whether or not the student is eligible for Medicaid, or helping them to be able to get to apply for and be accepted by Medicaid. And then proportional Medicaid, which I'll talk a little bit more about, or I'll show some different examples. Proportional Medicaid being what proportion of the overall school for free care or Medicaid administrative claiming, what's the overall proportion of the whole school that has Medicaid? So it might be a 60% Medicaid school, or it might be a 40%, which is where it's very important that we make sure that those who are eligible for Medicaid are keeping their eligibility and keeping enrolled in Medicaid services, because that eligibility does determine how much reimbursement is provided. Or whenever it comes to IEP services, it's of the total IEP population, what proportion of those students have Medicaid. So again, it's very important to make sure that our students are enrolled in Medicaid if they are eligible for that, not just for this Medicaid reimbursement, but also for other life events and other types of supports and services, so that the student is able to get health care and other types of care that Medicaid would be reimbursing in the community as well as in the school. Here are the time study codes. These codes, you can see that from direct service, what type of proportional Medicaid, the IEP ratio or the Medicaid eligibility ratio in direct service, or in the MAC indicator, you can see TM, which is total Medicaid, and the percentage of the FMAP is set for administrative claims at 50%. So you can see TM 50%, federal financial portion, or the medical activity portion. And so you can see those things, and then you see the proportional Medicaid for multiple other activities that I'm going to talk a little bit more about. I'm going to go into each one of these activities, talk a little bit about some of the examples of those activities, but also be able to talk about how some activities, if you've got people in the direct service provider pool, some activities that could be reimbursable for them and some activities that may not be reimbursable for them. Hopefully this information, although deep, is helpful for your decision making. First, when we're looking at non-Medicaid outreach, so we're not providing outreach to any particular Medicaid group, or outreach to be able to help individuals access services that are covered by Medicaid and considered eligible by Medicaid. So if that service doesn't take Medicaid, or is not eligible for Medicaid specifically, then that would be a non-Medicaid outreach activity, and this is unallowable, which means we can do those things, absolutely. They're just not going to be that percentage, or that random moment in time would be a non-Medicaid reimbursable random moment if I'm trying to connect students to non-Medicaid programming activities or benefits. For Medicaid outreach, if I'm trying to help students determine whether or not they're eligible for Medicaid, or I'm giving educational information to families, to newly pregnant parents, if I'm distributing literature around the benefits of Medicaid and eligibility requirements, perhaps the federal poverty levels and what 318% of the federal poverty level, what that that amount is, any of that type of those educational activities, that is all reimbursable by Medicaid for those moments and what's happening there. Also, if I have a student that we put out educational materials, we put out information, and there's some screening or activity that then I can help them apply for Medicaid, in facilitating their application for Medicaid, that would be a covered service as I'm helping them become eligible for that. I may be collecting or helping them collect different information or documentation that's required to become Medicaid eligible. Any of those supports that I'm providing, those are reimbursable by Medicaid. Facilitating application to anything that is a non-Medicaid program, including anything that is IDEA, that's non-Medicaid reimbursable. That activity is a non-reimbursable or unallowable activity. So we won't be able to see Medicaid reimbursement for those activities. Now, this is the first breakdown of that example. So that provider, and although this is rarely the way you're going to see it in actual reimbursement, it won't be per provider necessarily. It's going to be lumped together with the total direct and indirect cost. But I wanted to break it down per provider here so that you could see some of the reimbursement potential that can be brought into the district, and sometimes without a lot of effort to be able to do so. Throughout the process, you're doing the random moment time studies, and then on a quarterly basis, PCG will submit or will provide the reimbursement dollars to the district on a quarterly basis, these interim payments for the administrative activities that are occurring. Specific to Medicaid outreach, that is a uniquely better reimbursable activity or more reimbursable activity. When we're looking at this provider, they overall direct and indirect cost is $110,000. If 5% of the total district's random moment time studies equaled, if 5% of their time was on Medicaid outreach, we then multiply that by the total Medicaid rate. So this is Medicaid outreach is a unique set of activities that there's no percentage of Medicaid eligible students that gets classified into this. And so this is the total Medicaid. It's 100% times the federal medical assistance percentage, the FMAP that we've talked about before. And that is set at 50%, which is the minimum across the nation, but it's set to 50% and not specific to state by state. And so in this situation, if 5% is the case, then this particular provider on a yearly basis would recoup, or the district will recoup $2,750 for this one provider. You multiply that by 10 providers, that's $27,000. You, instead of 5%, if more of our providers are doing Medicaid outreach, and our staff that are in our staff pool are doing Medicaid outreach, if that's 10%, right now we're looking at, I don't know, $5,200, $5,400, something like that. So then with $5,400 for each one times 10, that's $54,000. And so I just wanted to break it down per provider. But when you see this multiplied in all the providers that we have or all the staff that are in our staff pool, that can translate into significant Medicaid reimbursable dollars. As I mentioned before, most of the activities that are Medicaid reimbursable are set on a proportional Medicaid basis. The only thing that is there is outreach and determination for Medicaid eligibility or application for Medicaid. Those are not proportional. They are total Medicaid, meaning 100%. The rest of the Medicaid administrative claiming or MAC claiming that occurs is based on this MER rate, Medicaid enrollment rate. This rate is determined by looking at the total number of enrolled students in the district that have Medicaid divided by the total number of students that don't have Medicaid. So again, the more I can help students that are eligible obtain Medicaid, one, I get reimbursed from Medicaid for doing those activities. Two, it helps my students get access to lots of different services and resources in the community, et cetera. And three, it actually changes the percentage that goes into my overall Medicaid reimbursement through the Medicaid administrative claiming, and it also will change the free care claims later on too when we look at the cost settlement model. In that cost settlement model that doesn't include Medicaid administrative claiming, that claim happens on an interim basis, on a quarterly basis, but instead this amount, this percentage will affect the cost settlement for free care or general education students receiving Medicaid reimbursable services, such as mental health services. When we look at Code 3, school related educational activities, here's a list of what all of those activities are that many times we have mental health providers involved in those activities. And if they're providing those services through a plan of care, it may not necessarily be classified this way. But if they're not providing it through a plan of care, it very much could be classified into this Code 3 school related and educational activities, which are unallowable reimbursable activities, not unallowable to do, just non-reimbursable activities. So we're not necessarily making, this presentation is not making a judgment on good or bad as far as what things should be happening, but instead, what does Medicaid see as something that is reimbursable? So this is not an allowable activity for reimbursement through any of your provider or your staff pools. And then when we look at IDEA or IEP services that are not covered by Medicaid, so these are mainly services that are provided by individuals that are not qualified to provide. So if they're not in that qualified direct service staff pool, as an example, if they're not in that pool or that eligibility list, then they're not qualified to provide mental health services or nursing services or PT or OT, et cetera, et cetera. So if they're not qualified, it automatically is going to make it an unallowable service that will not be reimbursable to the district. Providing transportation to non-Medicaid services, which can be, again, very necessary, but it's a unallowable service through Medicaid reimbursement. Now, providing services or supports in the coordination, the scheduling, the arranging, and the provision of transportation that is for individuals with specialized medical needs, or specialized transportation for those individuals, or providing transportation to Medicaid covered services that is a reimbursable activity. So when we're doing our random moment time study, that very much would come up as a reimbursable activity that would feed more into our federal percentage of reimbursement. Similarly, non-Medicaid translation services, so not related to Medicaid eligible services for Medicaid, for students that have Medicaid, that would be an unallowable service. But then providing those services for a Medicaid service and providing translation materials to an individual related to treatment services or care provision through the plan of care or an IEP for students that are covered by Medicaid, or providing your interpretation services or translation services, providing those for anything that's covered by Medicaid, any of the direct services that are provided, any of the outreach services that are provided, this service then would be reimbursable by Medicaid, and is actually reimbursable at a uniquely higher rate It's depending on your district. Some districts may be using this more versus others. A lot of times this is not utilized at a high percentage, but it is at a higher rate. So this is 75% of the federal financial percentage. And so we're looking at a higher reimbursable activity up to a 10% cap. And so there are some additional regulations that apply there. Looking at program planning, policy development, any coordination with multiple agencies and systems throughout that is absolutely necessary as we develop community schools and community partnerships and collaboration amongst our district with lots of different organizations. These activities are not allowable in this sense. And here's a list of what those are. These are typically the things that are not related to what's going to be considered medical services, but this is mental health, physical health, any of those types of things that are Medicaid reimbursable activities. So if it's not related to things that are part of the IEP, things that are part of the plan of care that are considered school health services, then that would be a non-reimbursable activity. On the flip side, when it is related to medical services or dental services or mental health services to the students there, any of that exploration of gaps and how to fill those gaps and planning around coordination of services and strategies to increase the capacity and utilization of these services and working with other agencies and supporting organizations as we're getting more students to be able to get services and supports to Medicaid providers throughout the community. All of those activities are reimbursable. And so having planning meetings and developing policies and working on interagency councils or local area networks or other types of systems of care work, any of that work on the programmatic or systems level, community level, that is reimbursable as long as we're focused on medical services, dental services, or mental health services for Medicaid eligible students for Medicaid eligible activities. And so if providers are taking Medicaid, then that would be considered a Medicaid eligible reimbursable activity. Training for non-medical, non-Medicaid related information, including child find programs for IDEA and other IDEA related things, is not reimbursable or unallowable to be reimbursed. While training for Medicaid and Medicaid related activities, improving the delivery, any training related to improving delivery of medical services and mental health services and dental services, or the delivery of Medicaid services, as we're talking about these activity codes right now, any of that related to enhancing the early identification or intervention, screening, referral, or EPSDT, or administrative requirements to medical and Medicaid services. Any of that training is a Medicaid administrative claim reimbursement activity. So that is an administrative activity that is reimbursable by both staff pools. Providing referral, coordination, and monitoring of non-Medicaid services, non-medical services to non-Medicaid eligible students or to services and activities that are not Medicaid eligible. You're seeing the theme here. That is unallowable. But then we can look at when we're focused on Medicaid eligible services that are referrals, coordination of services, monitoring of those services, anything related to gathering information, making those referrals over, participating in meetings, child and family team meetings, or any type of meetings that might be beneficial for the coordination of care. All of that with a Medicaid reimbursable service provider or eligible service, that is a reimbursable administrative activity. And these reimbursable administrative activities, They can be done by all of the individuals in our staff pools. So regardless of the staff pool, all of our administrative activities can be conducted by anyone in those staff pools. If you find someone that is in that staff pool that doesn't do any administrative related activities, doesn't do any direct service activities, anybody that does direct service, you want to put them in that staff pool. But if someone doesn't do any of these administrative activities that we're talking about here, and everything they do is unallowable, can be very important, but I would not put them into any of the staff pools because that's only going to bring down the percentage of reimbursement that will occur, and you won't get as many interim claims either through PCG for administrative activities or through your vendor for fee for service through direct service activities. General administration, things like taking lunch and having days off and things like that are just part of the it happens kind of thing. Now, it is important. I will say that you want to make sure that you update your schedule, the district schedule within PCG, because then you can get a random moment time study. You can get that request on a day off or something like that can very much affect this type of affect your percentages and your response rates, that you need to be able to keep good response rates of 85% of good reports back. We want to make sure your calendar is up to date in the system. But then sometimes I'm on break or I'm taking lunch or, I got sick that day or my kid got sick or something like that, that if those things happen, this gets reallocated to the rest. So it doesn't hurt, but it doesn't necessarily help either. And so those general administration activities get reallocated. Any time off that is unpaid time off is unallowable as well. So will not be reimbursable. And so with unallowable things, that reduces down our direct medical percentage. And so it reduces that down for our claims. All right, so here's the PCG quarterly type of reimbursement that you will experience as a district for Medicaid administrative claiming. This reimbursement is the non-outreach one. So you can look specifically at the Medicaid ratio here. This is a made-up number of 59.21%, or maybe it was a district that I worked with. But this number, you would want to recreate this Medicaid ratio number. And when you do your paperwork with PCG and you're putting in your reports, you will report this out, and your fee-for-service interim claim vendor will also be getting regular updates on what percentage of your students are actually have Medicaid, et cetera. And so that Medicaid ratio, that's going to be specific to your district and will be determined, as I talked about earlier, as the number of students with Medicaid in the district divided by the total number of students in the district. That's where that Medicaid ratio will come from. The direct medical percentage is what percentage of the time is Medicaid administrative claims or activities happening that are allowable activities. So that in this example, I'm putting the $110,000 provider with 10% of their time. I already counted 5% and outreach, 10% of their time multiplied by the Medicaid ratio, 59.21%, multiplied by the administrative federal medical assistance percentage, 50%, and that will give us $3,251.60 over the year. So I'm not going to get that every quarter. I'm going to get maybe a fourth of that. And oftentimes the first quarter, we don't get as much in reimbursement, but then it kind of it's heavier in the second, third, and fourth quarter throughout the year. So expect that's how some of your MAC or Medicaid administrative claiming Code 4B and 4C are all of the direct service provision of services for students with Medicaid that have IEPs and students that don't have IEPs but have Medicaid, so our free care population. When we're looking at this, we're looking at all of the services that can be provided if they are professional services within the discipline. So that's counseling, that's psychology, or that's psychological services, psychological testing, and other types of intervention, that's social work services and case management. All of these services are reimbursable, including some of the pre and post activities that are required for that, such as paperwork associated with it, development of IEPs or adjustment of IEP goals or reports back to the team with IEPs and to the family. All of these services are reimbursable services throughout the process and can be coded in this particular category that is a Medicaid reimbursable activity. Submitting claims to HFS is a multiple part process and comes through both PCG and through your fee for service interim claims that are submitted through the Medicaid administrative claims, which go to PCG, and claims that are submitted with fee for service that go through some kind of vendor that you're using, and it could be Embrace or Tames or something like that. And there's multiple vendors across the state. So those claims, though, all flow through Healthcare and Family Services. That's our lead Medicaid agency for all Medicaid reimbursement throughout the state. As we're looking at on the first side of this image here, we're looking at PCG, random moment time studies. As we're doing those things, we will get based on our cost report of how much cost there is, and then the random moment time study will get a percentage of the time that is reimbursable through interim administrative claims. And so then a payment will be received down at the district, or if you're a special education cooperative, those claims will, or that money will flow through HFS to the state comptroller, and then will show up in the district or cooperatives direct deposit, or however you have your payment set up from the comptroller. On the other side of this image are the interim direct service fee for service claim payments. This is for your fee for service Medicaid vendor. Oftentimes your providers, your direct service providers, are entering notes within this system, and within this system is where those providers, or that determination will be of, is the student eligible and has active Medicaid. Is the activity an allowable service, as we just covered all of those, and then we'll calculate that amount and provide an interim payment to the district throughout the school year. And that especially is important for cash flow. The cost settlement will eventually come around, and the cost settlement will take whatever's missing from all of the costs that's there from interim claims and specifically interim direct fee for service claims, and cost settlement will give the amount that the district is due. However, that does not happen without effort, such as completing our quarterly financials. And so it's important that our financial department is submitting these reports on a regular basis. On these quarterly reports, we have to submit what are the costs to the district, what are some of those, and then there's little guidelines here, and there's a lot of information that's available through PCG on what is appropriate, what should be reported, what shouldn't be reported. Also remembering that anybody that is any of your providers, direct service providers that are 100% funded by federal dollars, you don't necessarily put them in here, but you will put in any kind of federal appropriations within your reports, and that federal appropriation will reduce down your overall cost because you're not getting federal dollars for federal dollars being Medicaid dollars for things that federal dollars have already paid for. So that'd be kind of double dipping, so to speak. In our fee for service system, whether it's an IEP, a 504 plan, some other new health care plan that you're implementing for your general education or free care students. Um, you will have that plan. You'll provide the direct service that must match that plan as far as the services that were listed and the number of minutes or amount of time for the provision of those services. And then service activities would be documented within 6 months of the date of service. 6 months is the maximum amount. The goal is oftentimes to get it in quicker, especially if you want to be able to get those interim payments quicker. That can be a process or a strategy to be able to increase or reduce down your wait time for reimbursement. And so you can do that using all of the direct service providers that are listed over on the right-hand side. This includes our existing providers prior to the SPA and includes our new providers with the SPA. Now, something to note about the rates that you're going to get through your fee-for-service vendor provider. These rates are estimates based on the cost reporting system that you used back in 2020. So these rates are based on 2020. So if you're a district that primarily all Medicaid reimbursable services were happening through a special education cooperative, as an example, you may not have very high or maybe non-existent rates from 2020. And that means your interim reimbursement or payments will be lower. However, your overall reimbursement will not be lower. It's just your interim payments will be lower because these rates are based on 2020, and you maybe have not set higher rates. And at some point, the rates may reset. But if you are disappointed in some of the interim payments, that wouldn't be surprising if you weren't doing a lot of Medicaid reimbursable activities, or if you weren't submitting cost reports, or if you weren't working in PCG in 2020. If that was the case, those rates are going to be really low. Just expect that. But the cost settlement will still get you that Medicaid reimbursement amount, and you're going to maybe be seeing more in cost settlement than what you can get in your interim claims along the way. So as we're doing this, I want to also translate between cost settlement and some of this interim payments. So the interim payments will come two ways: the MAC, Medicaid Administrative Claiming, through PCG. We do that through the random moment time study, or fee for service for our direct service providers. We're going to do that through a vendor through the state of Illinois. And in that vendor, we're going to document the services that are happening. We're going to get a rate, and those rates are available to you. You can look it up at PCG to be able to find those rates for your particular district or entity. You're going to use that rate, and as you submit direct claims, you will get a fee for service rate. That is an interim rate. If your number ended up being higher, this will all flush out in the cost settlement model. So the cost settlement, we're going to take all allowable costs that are within your cost reporting, and then they're going to subtract. You're going to put in all of your interim payments that you've received, which you can find all this in PCG. You're going to put in all your interim payments that you received from the fee-for-service interim payments or from the Medicaid administrative claim interim payments. And then that's going to get to a total cost settlement that you will be able to see that. And I'm going to talk about the calculation of this, that it may take 1.5 to 2 years to be able to get those dollars back or that reimbursement there, but that money will be coming to the district. So it is something you can plan on and plan around. Here's an example of our sample provider that total cost for that individual was $110,000. When we're looking at direct medical percentage, keep in mind with the cost settlement system in the state of Illinois is that our direct medical percentage through our random moment time study of how much direct service is being provided. This isn't administrative claims. This is only our direct staff pool. So the random moment time studies may look very similar, but this is only our direct service staff pool. When we're looking at this 38.16%, That percentage is an average for the entire state. So it's not specific to your district. So this is an average for the entire state. So as we get better at this across the entire state, and we're all doing better in this, we may see the direct medical percentage increase. And this basically the translation of this is that approximately 38% of the time of all direct service providers that are in staff pools put into PCG across the state of Illinois, 38% of the time they are doing Medicaid reimbursable activities. And that's how you can translate this. So they are doing Medicaid reimbursable activities through 38% of the time. Then for the IEP cost settlement, then we're going to look at an IEP ratio. That IEP ratio is the percentage of students that have Medicaid divided by the percentage or the number of students that have Medicaid divided by the number of IEP students overall. And so oftentimes we're going to find in our IEP or special education system that many times more of those students will have Medicaid. So for IEP systems, we're oftentimes seeing a higher ratio here. Then we multiply that by our FMAP, our federal medical assistance percentage. That changed during COVID. It was a little bit higher, is 57% or something like that through the coronavirus or COVID specific relief law that put into place for a temporary relief. Our standard rate is around 51%, so 51.38%. So for this $110,000 provider, through all of these percentages, about $15,496 or $15,500 is what reimbursement will be for that one provider. And so we take the amount we had before with Medicaid administrative claiming, the different types of claims, and then the IEP cost settlement formula as well. And all of that adds up. But let's say you have 10 providers. If you had 10 providers, that's $150,000 or more than $150,000 in total reimbursement. So again, for the IEP enrollment rate, the proportional Medicaid are the number of Medicaid enrolled special education students with special education students with Medicaid divided by the total number of special education students. That proportional Medicaid is oftentimes much higher. Now, when we're looking at the single provider example for the free care cost settlement formula, the free care percentage, direct medical percentage, is 4.74%. This is across the entire state. So this is the state average for that free care percentage. We will likely see some of this increase. So we had 38% for IEP, 4.74% for free care. And as we get better at this, we may see the direct medical percentage increase. We take that percentage, the total cost, times that direct medical percentage, that approximately 5% of all direct medical or direct service providers in the state of Illinois, about 5% of those provision of services are happening with Medicaid students or students with Medicaid that have a plan of care that is not an IEP. And so that's what that percentage is, 5% of the time. We multiply that by the overall Medicaid ratio, the same one we use for Medicaid administrative claiming, and then multiply it by our FMAP for the state of Illinois, and that gives us the total medical allowable cost, and that's about $1,600 for that $110,000 provider or total cost for that provider. Again, we got 10 providers. That's about $15,000 that comes from free care as well. The biggest change I want to point out here is that, yes, there's free care, but you saw the medical percentage on that, the federal direct medical percentage from the random moment time study. These are still pretty low numbers, and the overall Medicaid ratio is almost always lower than the overall special education ratio or IEP Medicaid ratio. But the biggest increase that we're seeing is the movement from a rate settlement model of reimbursement to a cost settlement model of reimbursement. So that's going to be the 1.5 to 2 year delay reimbursement that will happen, and is very, very important that we have our cost reports in. But the vast majority of this extra $18 million in year one, extra $23 million in year two, and constant increase that we're hoping to see in year 3 and 4 and 5, that will be from improving how we're doing our cost reporting, making sure we're certifying those cost reports, and getting more funding through the cost settlement model. And then in the interim, our Medicaid administrative claims through the random moment time studies, and fee for service claims through our vendor that we use. Those interim payments will help us be able to pay the bills throughout that time, and we'll get that during the year. But overall, the cost settlement is one of the biggest contributors to the increase in Medicaid dollars that will be occurring. So it's very important to note, because staff pooling, cost reporting, and making sure that we're getting everything submitted on time, that is going to be the essential element to getting more Medicaid reimbursement dollars for cost settlement. There's a recently published in December 16, 2025, through the Illinois Department of Healthcare and Family Services, or HFS, this recently published Handbook for Local Education Agencies. This is your entire guidance of how to be able to implement these services, what's eligible for services, what's required for HFS. So if you want to dig into this more, that is your handbook that you want to visit to be able to learn more about. Here's some great resources for you to be able to explore and dig in deeper if you want to take an even deeper dive than what we have during this part of the webinar series. But I want to especially point out the Healthy Schools Campaign's Medicaid Expansion for School Health. That particular roadmap and tool with links throughout it is a very, very useful tool that can help you as you're exploring how to adjust practices and policies to be able to maximize Medicaid reimbursement. Stay tuned. The next webinar series, part 3, is an overview of community-based mental health services in Illinois. This is looking at our community partners and how can we use partnerships perhaps as a way to be able to expand mental health services within our district, or what services are out there that we can make referrals to, and what can we expect from our community partners throughout the state of Illinois. Stay tuned, and we'll continue this series. Thank you.